Hello and welcome back. I hope that you're well and you're having a good day and everything's going smoothly for you. Today, we are going to jump into chapter 11, which makes me so excited because I love working with children and youth, young adults. And so we're specifically going to look and learn about clinical psychology for youth as well as older adults. So we'll talk about two specialized fields in clinical psychology. The first will be child psychology, and the second will be geropsychology, which simply means the psychology of older adults. So we'll look at brief histories of each field and describe the unique features of assessment methods that clinicians might use when their clients are young and those that they might use when the clients are older. We'll also look at the most common disorders of childhood, adolescence, and old age, as well as empirically supported treatment for each. So let's jump into the history. After centuries of silence, we fortunately now are in a place where people are interested in understanding and addressing the needs of children and adolescents. There was a time when children were viewed as miniature adults, believe it or not. That makes me cringe when I think about it. Um, we now know that working with children looks a lot different than working with an older adult or adults in general. Child psychology is relevant to us all. We were all kids at one time, and abnormal child behavior is especially important and learning about if you're planning a career in teaching, counseling, medicine, law, psychology, and if you're a parent or just someone who is exposed to children in general. So, there have been changes that have come up in the DSM, the Diagnostical Statistical Manual of Mental Disorders. And some of those changes include age of onsets and course provided. Some symptoms are expressed differently for children, and that's further recognized. Just a quick example of that would be, oftentimes if a child's experiencing anxiety, they will complain about physical, more somatic complaints, which means body, like they might say their tummy hurts or their head hurts. And the DSM also considers whether behavior is developmentally inappropriate. So, something might be considered, a behavior might be considered appropriate if a child's 3 and inappropriate if they're, 13. And now there's clinical research and training designed specifically for, clinical child psychology, different programs, child development. And there's also 2 APA divisions devoted to clinical child psychology. So we've come a long way. And just to touch on, what research studies in abnormal child psychology seek to understand, one thing would be just defining normal and abnormal behavior for children of different ages, sexes, and ethnic cultural backgrounds. So thinking about, would the problem be viewed differently if the child was a different age, a different sex, or a different ethnic background? Research also looking to identify the causes and correlates of abnormal behavior. So internal and external, maybe making predictions about long-term outcomes. Will this better? Will this get worse? And develop and evaluate methods for treatment and other prevention. So how can we do to help this? How can we maintain it? Or how can we prevent this from happening in the future? Our society's interests and approaches have drastically improved compared to previous generations. And it's so beneficial to have baselines of knowledge about the history. Today we view children as delicate beings who need to be properly nurtured in order to thrive healthily and develop appropriately. However, this was not always the case, like I said. Um, before the 18th century, children with mental health problems were rarely mentioned at all, even in professional settings, which blows my mind. Church used its strong influence to attribute children's unusual behaviors to their inherently uncivilized nature. People believed abnormal behavior was due to things like possession of the devil. And Extreme measures were often taken. Unfortunately, children suffered from cruel acts of physical, sexual abuse, as well as neglect, which was considered at one time an adult's right in the education or disciplining of a child, which probably makes your stomach turn, right? Just like it does mine. And so there was in Massachusetts, a Stubborn Child Act of 1654 was put into place, and this permitted parents to put stubborn children to death for misbehaving. Children considered nothing more but parents' property, which is really, really sad. And so, fortunately, by the end of the 18th century, there was an interest in abnormal child behavior, and more research came out, and our thinking about child's development shifted for the better. So children are not just miniature adults, like we know, and there are unique characteristics of clinical child psychology, right? So there are differences when we work with minors versus when we work with adults. One of them is we're often focusing on developmental stages. So we're accurately determining what behavior is typical versus what's atypical or not typical for their developmental stage. And their developmental stage also may shape explanations of diagnosis and treatment so as to be understandable to their families and themselves in general. We're also looking at the context of their behavior. So context has greater influence for children than for adults. And that's for a couple of reasons. One is that children's behaviors are generally more malleable, meaning they are more prone to changing based on their environment. So for children, the environment can act both as a risk factor for psychopathology and a protective factor against it. For example, having friends who use drugs is certainly a risk factor, right? We know from studying child development and teen development and just, human nature in general, that we are heavily influenced by our peers when we are in a certain age bracket, okay, specifically adolescent years. But if we have a relationship with a trusted adult at school, or we have a really stable, reliable home environment, that serves as a protective factor. Adults, another reason why context differs is because adults have more power, right? When you're a kid, you kind of have to go with what your parents or caretakers tell you. Adults can decide where they live, when they go to bed, what time they wake up, what they eat, who they spend their time with. Adolescents and children have far less control, if any, in some cases. So younger children especially must live with the decisions that their parents make for them about things like their daycare or school, what options they have as far as food goes, daily routines, and so on. So the influence of environmental context on children's behavior has to be taken into account when we are, conducting an assessment and working with a child. So there's also different ethical components when we're working with children in therapy. First of all, no child refers themselves to therapy. Okay. If we have a teenager, maybe, but children, no. And, they're minors. So therefore their parents have certain rights. They have rights to, know some about their child's treatment, not all. There's limits of confidentiality when working with minors, and that's a whole different topic. But for the most part, the parents have the power. I've worked with clients, unfortunately, who I made a CPS report because there was, abuse or suspected abuse going on in the home. The parent finds out, because social services show up at their door, and, their therapist is often one that they might blame or just know it's them, even though social workers aren't supposed to tell them who made the report, and they pull them out of services, which is detrimental in a lot of cases, right? So with adolescents, most therapists keep information confidential unless the clients endanger themselves. If they're saying that they want to kill themselves or harm themselves or someone else, then that's a different story. Of course, we would always involve the caretaker or parent. But for the most part, we have a conversation with the parents when we're working with adolescents that, in order for treatment to be effective, we need to build a strong, trusting relationship, the client and I, and therefore, it would not be ethical for me to share every single thing with you. Of course, we reassure the parents if there's any type of safety concerns or pressing concerns, we will inform them. And also, if there are other things that we feel like you should be a part of, I will have a conversation with, the adolescent that I'm working with, if we could involve you in that and kind of what that looks like. Children, really little children, maybe like, I don't know, maybe 7 years old or younger, you might share a little bit more with. Again, it all depends on why they're coming for services. But, just to kind of put this all together, we consider various different factors when working with children than we do, adults or older adults, as well as their different context of behavior. And we also have to consider that the ethical components of treatment in of itself is very different. Okay. When adults seek services for their children, it's not often clear whose problem it is, actually. Sometimes it's the parents' expectations that need to be adjusted. Sometimes often it's a family dynamic concern. There's many, many times when parents might have misconceptions about what therapy is, and they may kind of have this idea of you're going to fix, and I put fix in quotes, in air quotes, my kid, and we have to kind of explore that a little bit and what that looks like for them, and maybe kind of shift their expectations because all behaviors are a form of communication, and typically there's more to it than a child just deciding that they want to misbehave. Okay. So our interventions are often intended to promote further development. So the goal for treatment is not usually to restore previous level of functioning, rather to promote further development. We want the kiddos to thrive, right? And this is different than interventions for most adult disorders. Okay. One more thing that I'll say about, on this slide is that many problem behaviors in youth are not entirely abnormal. Think about yourself as a teenager. I know that I cringe when I think about certain things that I did. Teenagers are a lot more impulsive, risk-taking, maybe a lot more moody, right? We go through puberty. And it's not because something's wrong with them. It's merely their stage of development. The front part of our brain, which is the smart part of our brain, prefrontal cortex, I often share with the families that I work with that's the last part of the brain to develop. It's the part of the brain that involves thinking long-term, rational thinking, impulse inhibition, etc. So, it's actually normal in some regard for the child to or the adolescent to be presenting in a certain way. Of course, we want to give them the support and the means and the education on why it's important to make healthy decisions and smart decisions. But really, a lot of that has to do with how the family is existing with one another and what values they place on things, and the strength and the connection between the child and the parent or parents, and so on. So there's differences too when we are doing an assessment for a child. So as we know, as we talked about early on in our early modules, when we first begin seeing a client, we do an assessment. There's a decision-making process. We must determine, and so when we're working with children, we must determine whether the child's presenting concerns requires professional attention or whether it's within normal limits of their developmental stage, and they may very well grow out of it. But in order to come to that conclusion, we have to begin with a clinical assessment, right? So to remind you, a clinical assessment uses systematic problem-solving strategies to understand children with disturbances and their family and school environments. So not all of our assessments will look the same. It differs based on your work setting, what type of modality you practice, and so forth. But an assessment for a child usually looks at the child's emotional, behavioral, cognitive functioning, as well as their role of their environmental factors. Okay. So what their household is like, what school they're attending, and things, how they're spending their time, where they're spending their times, things like that. So we are typically assessing across different environments. So we want to look at, okay, so we're saying that, this behavior is presenting itself and it's concerning. Is that happening both at school and at home? Is it just at school? Is it only at home? Because that gives us some information too. And our assessments need to be flexible, because we won't always get all of the information that we need right off the bat. Things will pop up later as we get to know the child and start to work with them. Something might present one way, but evolve into something different over time. Also, there are various factors in which you must constantly assess for, right? We need to always be listening for any safety concerns, self-mutilation, abuse, and so on. All of the assessments that we will be looking at or talking about and what you'll be reading about are valuable in eliciting information from parents and school-aged children. One is our behavioral rating scales, or a behavioral assessment. So a behavioral assessment evaluates the child's thoughts, feelings, and behaviors in specific settings, which can lead us to formulating a hypothesis about the nature of the problem and what can be done about it. Okay, so we have primary problems of concerns, and that's targeting behaviors and factors that control or influence them. So this involves observing the actual behavior. So as therapists, I know this is something that I do a lot because I am school-based. I work with the schools. I'll go into their classroom and observe their behaviors with peers and with the teacher. We can't usually just ask why the child's doing what they're doing, right? I'm not going to sit there and say, okay, why do you keep getting up from your seat, and why can't you sit still? Well, likely the child doesn't know. It's just something he feels like he has to do. Okay. And if I go in and observe, I could see, how often this is occurring. So the frequency, how long it's lasting, the duration, as well as any antecedents. So if there's anything that takes place before and any potential consequences, or maybe it's that they have a lot of extra energy. Maybe they, might have ADHD, and we need to think of ways that the child can effectively release that energy. So commonly, just to know, I kind of noted this, but a commonly used and simple framework for organizing findings in a behavioral assessment is called the ABCs of assessment. And this is just for your recollection. And it's really to observe the antecedents. So that would be the A. So events that immediately precede a behavior. So let's say that we have a child who often says that in the mornings, they say that they feel sick, or they're actually getting sick or making themselves sick. what is happening right before that? So, mom wakes up the child and says, okay, it's time to go to school. The behaviors, and this is usually why the child is coming to therapy, is maybe that they are crying a ton. Not, like I said, they're feeling sick or making themselves sick. They are immobilized. They just can't, they can't get themselves dressed, or it's almost like they're frozen. And then the consequences. So the consequences of those behaviors are the events that follow a behavior. So maybe the parent lets them stay home, or the parent gives them additional attention and comfort and things like that. So we're looking at the ABCs. So what happens before the behavior, the actual behaviors of interest or the concerning behaviors, and then the consequences, if there's anything that they're getting out of it. Okay. And just to know, if a child's actually physically getting sick, then that's a pretty severe anxiety. That's not their fault. They're not thinking in their heads that, okay, if I get sick, then I'll get to stay home. Sometimes that kind of thought pattern takes place with kids, and that's just because they're really smart and they have creative ways of getting their needs met. But just for that particular example that I used, in that case, I would kind of do things a little bit different, because it's clear that this child is, having a really crippling anxiety that needs to be dealt with. Behavioral rating scales are inexpensive and relatively easy to administer. They're usually reliable and valid for their intended purpose. And they're nearly always completed by the parents and at least one teacher. So that's like that collateral information that you're getting from multiple sources, because the child's not going to be the one to fill it out. So clinical interviews, you should remember this because we talked about the different types of clinical interviews. They are like good detective work, right? We are assessing multiple domains. We're looking at their presenting problem, what led them to treatment, their current and past behavior, detailed history, attitudes, emotions, and so forth. And that they can be structured or unstructured. So structured, we ask them the exact same question in the same order, but can be limited. And if we're using a structured approach, or unstructured is a lot more open-ended and may result in low reliability and biased information. Clinicians must use their own judgment as to whether a child's behavior is unusual or inappropriate for the child's developmental stage. And in order to do that, we have to get a lot of detail and information about, what's going on. We have intelligence and achievement tests as well. And these are measures to evaluate a child's intellectual and educational functioning. There are many definitions of intelligence, although debate remains about how to define intelligence. The tests are primarily used in clinical settings to identify children who have difficulty succeeding in a regular classroom setting, and maybe need some additional accommodations or interventions. Many of you have probably heard of IEPs, or individualized education plans. Typically the way these come about, or one of the ways, is by an intelligence or achievement test, kind of determining that the child just needs some accommodations or additional intervention to help them succeed in schools. The most commonly used intelligence test is the Wechsler's intelligence scale. It emphasizes fluid reasoning abilities, higher order reasoning, and information processing speed. And the most commonly used achievement test is the fourth edition of the Woodcock-Johnson, or WJ, people often refer to it as. And this is individually administered norm reference instrument, and it's useful for screening, diagnosing, and monitoring progress in reading, writing, mathematics, achievement areas for people from actually 2 to 90 plus years old. So, you'll learn a lot more about these types of achievement tests and intelligence tests if you do pursue grad school. Moving on to, I'm actually going to make this font a little bit bigger for you guys to see a little better. There we go. Okay, so clinical assessment for children, we're going to continue talking about a few more. Projective tests are rooted in psychoanalytic tradition. So we talked about psychoanalysis and where it's rooted from, Sigmund Freud. We all probably agree and heard that while his ideas were a little off at time, he did bring to our attention the presence and influence of unconscious processes in psychological disorders. We know that they're not all related to sexual desires, but they certainly hold merit in our psychology. So if people aren't aware of these thoughts, repressed thoughts, how do we assess for them, right? If we're not aware of them, then how do we assess for them? Well, this is where projective testing comes in, or the idea of projective testing. So it's used to assess unconscious processes. The theory is that people project their own personality and unconscious fears onto other people and things and reveal their unconscious thoughts to the therapist without necessarily realizing that they're doing so, right? Anything having to do with psychoanalytic theory is controversial. So these are, not everyone believes in them, and that's okay. But the idea is that we project aspects of personality onto an ambiguous test stimuli. So this requires a high degree of inference in scoring and interpretation. So like right here, with the picture that you see, that's called the TAT, thematic apperception test. And the idea behind that one is that, the person would give a series of cards with pictures on them, and, they are asked to describe what they're seeing, and it's designed to reveal in individual's perception of interpersonal relationships. Okay. And then the Rorschach, which is these ink blocks, and it's probably something that you often see like in movies and things. This test the idea is that it helps in the understanding of personality dynamics from perception. Whereas the TAT is used to understand personality dynamics from apperception, right? So to put in simple words, the Rorschach test scoring depicts how the person sees the world. And the TAT focuses on how the person understands or made meaningful people's motives, expectations, intentions, and social situations, etc. And then we have behavioral observations. Children's problems usually occur at home or at school. So observations in these settings give therapists the opportunity to validate and gain new perspective on and resolve discrepancies between reports made by parents and teachers and we do this through rating scales and interviews. So, just as an example, maybe a parent is saying that their child is extremely anxious, but the teacher is reporting otherwise. The teacher is saying, no, I don't notice that at all. They're interacting fine. They're engaging, no problematic or concerning behaviors. So the therapist or psychologist might go in and observe the child, and they might come to find out that the child does in fact have anxiety in the morning, but as soon as she, gets with her friends or the people she's comfortable with, she warms up. So this is an example of differing but accurate reports of behavior affected by social context, right? So observations might instead show that the child remains anxious all day, but that the teacher has so many students with more noticeable behavioral problems that a quietly anxious girl is not noticed. And that's where a therapist might come in and notice that, no, the child's not acting out. She's actually really good, but she's also very withdrawn. And typically teachers have, so many students on their hands that The ones who are acting out or are a little bit more loud are the ones they are paying the most attention to versus the quiet ones, the ones that kind of slip through the cracks. Classroom observations often concentrate on behaviors associated with ADHD. So I'll get referrals for, the child being really disruptive or like the class clown or impulsive, non-compliant, difficulty paying attention. Some observations include structured scoring, but most are informal. Most you just go and just simply observe. Okay. And then when you're working with children, we also have to understand and deal with inconsistent assessment information. So, it's possible that a parent maybe exacerbates or over exaggerates the symptoms, and maybe the teacher just isn't noticing it as much. Um, uh, therapists must consider all sides and whether there are any secondary gains or if it's just a simply a perception, a difference in perception or biases, and not that they're necessarily conscious or purposeful. But parents and teachers especially may tend to see certain children in generally positive or negative light that colors their view of everything, of everything that the child does. So if we talked about labeling and things earlier on, so if a teacher right away before they've even met the child notices, hears that is notified that the student, one particular student has ADHD, that might bias or make them a little bit more biased and hyper focus on maybe all of the challenges that the child has versus all of their strengths too. Even if it's not, like I said, maliciously, it's just a natural human thing that, okay, I learned this about that, therefore I have my own views on what a child looks like who has ADHD, when we know that they're all unique. So, in short, clinicians must consider motivational factors in assessment data rather than simply accepting them at face value, and so forth. Okay. So let's talk about treatment and prevention of childhood disorders. So over the past 2 decades, effective treatments for youth with behavioral or emotion problems have grown, which is wonderful. There are childhood disorders, so disorders that diagnoses in the DSM that are specific to childhood. And these are commonly autism or ADHD. There's conduct disorder, oppositional defiant disorder, ODD. And then, of course, we know that children can also suffer from anxiety, depression, and so forth. So common treatments for anxiety and depression are, like we keep bringing up, cognitive therapy, cognitive behavioral therapy, and interpersonal therapy. So we went over kind of what these approaches entail already. Common treatment for ADHD, ASD, autism spectrum disorder, conduct disorder, and ODD are more behavioral. So behavioral modification. So contingency management for peers, teachers, and parents. And then we have pharmacological interventions as well, and this is medication. So for ADHD, we might have stimulants or amphetamines, which work reasonably well. And for anxiety and depression, we have SSRIs, so selective serotonin reuptake inhibitors, antidepressants may have negative effects, though, so we have to consider the evidence. And of course, they have to work with their doctors, weigh out the pros and cons, and so forth. We want to always make sure that the gains will outweigh the risks, right? So we plan our interventions by combining the most effective approaches to our particular problem with what we're seeing that's unique to the clients. And this all begins with a thorough assessment, okay? The most useful treatments are based on what we know about a particular childhood disorder. So like what this slide highlights, we know that the research shows that CBT or interpersonal therapy works really well for anxiety and depression, while behavioral modification or behavioral therapies work well for, conduct disorder, ODD, and so forth. But we want to consider too that multiple problems require multiple solutions. So we might have one component of behavioral therapy that works really well, but we also might decide, after our assessment of the child or some time working individually with the child, that there's maybe a larger systematic issue at large, and that, family therapy would be really beneficial. But across the board, we want to, like I said earlier, we want to reduce the symptoms and also produce more substantial changes that will enhance the child's long-term functioning, right? So just some outcomes related to child functioning. We, of course, want to reduce and eliminate the symptoms. So if they're coming in because they're having anger outbursts or self-mutilation, self-harm, and things like that, of course, we want to either reduce it or eliminate it. If it's an emotion regulation thing, that's typically, we want to reduce it. Where if it's thoughts of suicide, we always want the goal is to actually eliminate that. We want to reduce the degree of impairment and functioning. So we want them to, um, be more successful in school or at home. If they're avoiding school due to anxiety, we want to obviously reduce that, get them to a place where they can go to school and, have tools to cope with their anxiety. We always want to also try our best to enhance social competence. So function within a peer setting, that they're making friends. Again, depending on their chronological age, if they're in school, we want to think about, how they're functioning amongst their peers, as well as improve academic performance. And typically that's not a problem. When a child has a mental health concern, of course, it's going to impact their functioning in school. So a lot of times when we, get to the root of the problem, any resistance towards school does subside. Unless, of course, there's a learning disability or things like that. And that's why you have, those intelligence testings that you can refer for. So we have therapy and also medical and medication interventions, and sometimes both are needed. Sometimes it's one or the other. It's really just unique to the client's specific needs. And we also have to consider their culture. Some families won't believe in medications, and we have to meet them where they're at, regardless of our views. Okay. Sometimes though, medications just needed to make the child more available for treatment if it's a more severe condition. So the future of child clinical psychology, although advances in clinical child psychology have lagged several decades behind developments in adult clinical psychology, the child field is catching up rapidly. In addition to the trends that we have mentioned in the book and in the PowerPoints, a number of other trends are likely to characterize the future of child clinical psychology. Okay, so specifically speaking to diversity and multiculturalism, we need evidence-based treatments for diverse population. The characteristics of people under 18 are even more diverse than they are for adults, which makes the topic of diversity and multiculturalism especially relevant for clinical child psychology. There's a great deal of interest in promoting culturally competent practices in clinical psychology, as there should be. And in clinical child psychology, excuse me, both in the US and around the world, the goal is important because many of the traditional psychological treatments that were developed mainly for the majority populations tend to be less effective for youth from single parent homes and disadvantaged and ethnic minority backgrounds. So researchers in clinical child psychology are seeking to tailor psychological treatments in ways that make them more relevant for youth and family of a variety of backgrounds, which is wonderful. And then there's access to care. So 25% of children who need treatment have no access. Fortunately, we are we live in a digital world now, and technology has dramatically changed the lives of children and adolescents over the last 3 decades. But we have to also look at that. Yes, 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 there are pros in that the treatment's more readily available if they don't have a ride. In the state of California, uh, adolescents or children who are 12 or older and deemed mature enough can consent for their own treatment. There has to be a reason why the therapist would allow them for treatment and not let them consent for their own treatment and not involve their parents. So for example, if the parent's abusive, or maybe the child, I had a teenager I worked with who referred herself because she was transgender, but that went across, against her family's belief systems, and it wasn't safe at that time to involve her parent. Eventually we did, as we worked towards a place. And but in that case, she was deemed to be mature enough to consent for her own treatment, and there was a valid reason why we weren't gonna include her mom just yet at the beginning. But then there's also the downside of technology, right? Especially for young people with psychological disorders, they're just more prone to having an adverse effect or having an adverse reaction. Online interactions are more likely to be poor quality, less positive and affirming, and more likely to lead to what some researchers have called internet addiction. And although it's not certain whether compulsive internet use is a true addiction, it's actually they're doing a lot of research on it. It should not be surprising because these adolescents, the ones who have the psychological disorders, are the ones who are most likely to also have difficulty with in-person interactions, right? So in other words, for them, the online context may simply be another arena in which the symptoms of their disorders appear. So additionally, these young people may be more vulnerable to the negative effects of poor online interaction and patterns of internet use. We know that people have a lot more confidence and will say anything behind the screen with the screen's protection, cyberbullies and things like that. We all know it's a real thing, but for someone who is more well-adjusted and considers all aspects, hey, this person doesn't even know me. I'm not going to let it get to me. I actually feel bad for them that they even have the time to go that far, versus someone who is more emotionally disturbed and maybe doesn't have a lot of resources or coping mechanisms, might take that a lot harder. And, it could be dangerous. Your book has the statistic of about 23% of adolescents experiencing cyberbullying and worrying about the potential negative effects of cyberbullying or what's going to happen when they go to school the next day. And then the outcomes of that is often anxiety and depression, or even thoughts or completed suicide. Unfortunately, I think that I would say it's probably a lot higher than 23% of students who experience that. So, technology, as we all know, comes with pros and cons. We have to use it in a healthy way, promote it in a healthy way. Many troubled adolescents want help, but fear that what they see as a stigma or associated with seeking treatment, that people will judge them, or, they can't be honest. The internet can actually help them overcome this barrier by helping these people find others who are experiencing the same problem. And they might feel less alone or more motivated to get help. So, it could have the same effects on parents too, who are in need of help, or maybe, need a little bit of encouragement to seek support. So it can be used in a really positive light. We just have to use it the right way. And then the last thing I'll say is that when we're working with kids, it's often we're working with an interdisciplinary team. That meaning that we often work with more than one person. So we're collaborating with their teacher. Maybe there's a social worker involved or a school counselor involved. If we're, in a private practice setting, we might reach out to the school counselor and all work together and make sure that we're all on the same page for continuity of care. All right, let's move on to clinical geropsychology. I'm going to just take a quick breath. I know I've been talking a lot for a long time. And we're going to transition to talking about working with older adults. So as I said, clinical geropsychology is the application by psychologists in a range of subdiscipline. So clinical psychology, counseling psychology, of the knowledge and methods of psychology to understanding and helping older persons and their families to maintain well-being, overcome problems, and achieve maximum potential during later life. So clinical psychology discovers older adults' personal growth, but the field of clinical psychology initially showed little interest in old age. And this was partly because early developmental and psychoanalytic theories were concerned primarily with the early stages of life, viewing them as the key generative period that paved the way for adulthood. So once maturity had been achieved, development was assumed to be complete, with little or no meaning changes occurring between early adulthood and the end of life, which we know sounds silly, right? Similarly, through clinicians recognized the existence of mental health problems in older people, such problems were regarded mainly as continuations of disorders rooted in childhood. So the first influential proponent of this view was developmental psychologist and psychoanalyst Erik Erikson, which you've probably heard about Erikson in multiple psychology classes that you've taken. Erikson regarded life as a constant process of psychological development and argued that changes in later life were just as critical as those in childhood, even though they occur less rapidly. He explained that psychoanalytic model of developmental conflict to cover the entire lifespan. He saw late, middle age, and especially old age as critical capstone stages during which life experiences and circumstances either helped or hindered people's ability to remain productive, engaged, and just overall satisfied with their life. And then there's Robert N. Butler. His landmark study, Human Aging, was among the first to dispel the misconceptions that cognitive decline was an inevitable consequence of aging and to show that disease, not age alone, led to dementia. So it's not just because you get older that you get dementia. It's, these things take place, which causes the dementia. He was also the first to address the subject of discrimination against older people, also known as ageism. So he coined the term ageism as a source of negative stereotypes about and discrimination against older adults. So he was the first to recognize that, hey, we have this stereotype against old people, even though we all get there at some point, right? There's no fighting aging. There's things that you could do to prolong it, right? And stay healthy, but we all get older. So why do we treat them any less important if we're all going to be there at some point? But there is still a need for more geropsychologists. It's in high demand, but there's still not nearly enough of these professionals available. And there's a shortage of geriatric psychiatrists and geriatricians, as well as social workers, nurses, dentists, pharmacists, speech therapists, and rehab therapists trained to work with older adults. So it's not just psychologists that there's a shortage of people who specialize in working with older adults. There are several disciplines that are struggling with the same shortage. So unique characteristics of clinical geropsychology. Geropsychologists have a uniquely sophisticated understanding of older adults' strengths, as well as their unique constellations of challenges that commonly arise at this phase of life. We are aware of the best research on aging, such as studies showing that most individuals' mental health improves with aging, actually. But with this in mind, we don't make the all too common assumption that aging itself is inherently difficult or depressing. We are also aware of the particular challenges that tend to face older adults and become more common with advancing age. So, things that tend to pop up like physical ailments, the longer you live, the more loss that you have, and things like that. We understand ageism and the intersections of age and other marginalized identities that create particularly negative outcomes for too many older adults. Some geropsychologists focus more on end-of-life care, while others specifically work with older adults who have dementia or may even work with them and their caregivers. That said, the specialty is much larger than the two Ds, dementia and death, right? Geropsychologists also help clients adapt to changes in their roles with their families, such as becoming a grandparent or a full-time caregiver. In addition, the roles kind of flip, right? At one point, you're caring for your child, and after a certain point, they might be caring for you. A geropsychologist can help navigate the often choppy waters on the journey to a meaningful and rewarding retirement. That often retirement is a big adjustment, and it can be hard to find, have meaning through that time because, maybe your kids are often older and have their own families, and then a big source of your identity was working, and so it could be a difficult adjustment. They can help grieve their losses, mitigate isolation, and, just live their best life regardless of the illness that arises. Of course, too, there's management and help processing for cognitive changes, experiencing ageism in of itself, and other potential stressors. So the work setting are primary care doctors' offices, and there's also geriatric clinics, or long-term and assisted living facilities, or even home-based and palliative care. All right. So clinical assessment for older adults. When conducting assessments, geropsychologists must also keep in mind that about 80% of clients over the age of 65 will have at least one chronic health condition, such as diabetes, hypertension, arthritis. And some of these health conditions produce symptoms that overlap with the symptoms psychological disorders have. So, and that can make it challenging to determine if it's the physical ailment that's causing the symptom or the emotional distress. So, hypothyroidism can cause symptoms of that look like depression, and even deficiencies of vitamins like vitamin D or B12 can create depressed moods or reductions in cognitive ability. At the same time, psychological disorders often create physical symptoms as well. So anxiety causing stomach aches or headaches or things like that. Older adults are more likely to focus though on their physical symptoms rather than their psychological ones. So the geropsychologists are particularly careful to obtain a detailed medical history in their assessment and often collaborate closely with the client's doctors. There are different types of assessment methods. So standard and age specialized clinical interviews are often used, self-reports, neuropsychological measures, dementia, screening for dementia, working with the family and getting their reports, and of course their medical records as well. And it needs to be recognized that some instruments have not been validated with older adults. And so there's always a use, when using them, we must use it with caution in interpreting the scores. So treatment of older populations and, the special considerations we need to recognize. Clients may have significant impairments in cognitive processing, speed, memory, and reasoning, and we need to be mindful of that and also, have patience. And then, of course, older adults have both medical and psychological disorders, each of which can worsen the other, and complicate assessment and treatment. Depression tends to magnify the pain associated with a physical or medical condition, thus limiting a person's ability to enjoy their favorite activities, leading to a further decline in mood, right? And older adults who believe our society's negative stereotypes about older people, such as that they all have bad memories or shouldn't exercise as much or have no interest in sex, may underperform on cognitive tests, avoid working out, and miss out on important sources of pleasure. So it's kind of like this self-fulfilling prophecy. And if they have, are not at peace with aging, or actually have these beliefs that, oh, I'm old, so therefore I can't be active, then they're not likely, to try. So it's internalized ageism. Geropsychologists also must recognize that older adults' perceptions of and expectations for treatment, as well as their views about privacy, sexuality, gender roles, and other topics that are likely to come up in psychotherapy, can differ significantly depending on when the clients were born, right? Things change. Members of the baby boomer generation, for example, tend to be relatively open to receiving psychological treatment and generally hold positive attitudes about it. But members of earlier generations may view the need for mental health services as a personal or spiritual failure. So we have to also consider the time that they were born. Additionally, older adult clients may present geropsychologists with problems other than psychopathology. They may need help to cope effectively with the stress of retirement or moving in with an adult child. Um, Changes in how they can perform physically, coping with the stress of bereavement. Like I said, the longer you live, the more people you're going to lose, the more people, you're outliving people, and that's really, really sad and hard, and coming to terms with, like, I'm getting older too, and there might be some existential work that you do. And then, of course, ethical considerations, regardless of the population we are working with, whatever treatment target that we're working on with an older client, geropsychologists must remain aware that older adults' medical and cognitive problems can interfere with their capacity for, insight and judgment. Capacity is a legal as well as clinical term that pertains to a client's ability to make decisions, including the decision to continue and consent to treatment. If an older adult doesn't have the mental capacity to make the decisions, the geropsychologists may not proceed unless someone, in their family or some other healthcare surrogate is available to give permission. Okay. So those things all have to be taken into consideration. And treatment of older adults in treatment settings, we could do, just like with any other individual, couple, or family therapy, within a private practice, mental health clinic, other outpatient settings, inpatient hospitals, or partial hospitalization facilities, PHPs. Treatment can be utilized from a psychodynamic, behavioral, cognitive behavioral, interpersonal, and humanistic approaches, all of which we've talked about. We put a heavy emphasis on evidence-based treatment. Acceptance and commitment therapy has also been shown to be promising, really focusing on values and whatnot. And then, of course, there's pharmacological treatments. Many older adults prefer to address their problems through psychotherapy rather than prescription drugs. However, research suggests that they may sometimes benefit from a combination of the two. But still, for several reasons, geropsychologists and geriatric physicians must be cautious when including drugs in a treatment plan. As you get older, older bodies absorb distribute, metabolize, and eliminate drugs differently than younger ones do. Unless you're a psychiatrist, I mean, we're not the ones, psychologists aren't the one prescribing the medications, but it's certainly something to consider. Um, Also, older adults are likely to be taking several medications already if they do, have a condition or a chronic medical condition. And so it has to be taken into account of negative drug-drug interactions. We want to make sure that they can work effectively with one another, and it's not going to, cause harm taking these two things at once or more than one thing at once. And also, many psychotropic drugs, including older antidepressants and antipsychotics, can increase the risk of falls, impair cognition even more, and have other negative side effects that might just completely outweigh their benefits. Fortunately, newer antidepressants like SSRIs or SNRIs have lower risk for older adults, so it's vital for geropsychologists to work closely with the medical providers to talk about those concerns. And lastly, the future of geropsychologists. Your book notes by 2060, whites will make up only 55% of the over 65 population. African Americans will grow to 12%, Asian and Pacific Islanders to 9%, and Hispanics to 22%. Other facets of diversity include immigration history, gender identity, sexual orientation, education level, etc. So the expanding diversity of the older adult population will make it even more important that geropsychologists have assessment instruments that have norms for all various combinations of clients' age, ethnicity, race, and the like. And in addition, just like with everything, technology is playing a role. Geropsychologists may be called upon to help older adults stay productive and engaged on the job as technology advances. There's some things that you just can't do the old-fashioned way. Sometimes it's like you have no choice but to go digital. So some of the work might be adapting to that and learning to navigate it. At the same time, advancing technologies are helping to address some of the challenges associated with aging, including social isolation and loneliness that can have a serious negative impact on physical and mental health. We see that loneliness is, through COVID and the lockdown, it was a horrible thing and had a lot of negative consequences, was that isolation. I know for me, my grandma had learned how to do FaceTime, and gosh, she even has an Instagram, and it's cute, and also a great way to stay in touch. So it's nice. We have a family member, my sister lives in Canada, and she's really close with my grandma, and they FaceTime all the time. So those things are really cool because it helps, our grandparents and older adults feel more connected. So as network devices in homes and, internet and things like that become more prevalent, it will become easier to monitor the health and activities of older adults. So that's a positive component too. So that wraps us up. I hope that you enjoyed and learned something from this lecture. You're going to watch a few different complementary videos. One is a TED Talk that is extremely interesting on working with children who have endured significant trauma and kind of play-based interventions. As she just talks about it, it's not a demonstration. And, just listening to hard stories. And then also cognitive behavioral therapy techniques for older adults transitioning to long-term care. You'll have a quiz that you'll work on and a discussion board as well. So it's a little bit of a heavier week. But if you have any questions at all, please, please, please reach out to me. As always, I'm in your corner. I'm supporting you 100% of the way. A reminder that even though this is online asynchronous course, you are not alone in this. We are in it together, and I've so appreciated getting to know all of you up until, this point, and I'm looking forward to the rest of the term. Okay, take care of yourself.